Good afternoon. I'm Mimi Kiser, and I'm at Emory University in the School of Public Health and the Department of Global Health. I'm honored to be here. Thanks for the invitation. And I'm honored to be representing 10 sites that I work with and sharing with you elements of their work that I think might be useful for this conversation here today. Emory University is distinctive in an area of scholarship and teaching and applied work in the idea that religion is a social determinant of public health. So it's from that field of work that I speak to you. Scroll. What I'm going to do in my time is to give some background information about a project that has demonstrated reach to vulnerable populations. In this last 7 years, the focus has been around influenza prevention services in community settings. So it's the actual services outside of healthcare, but sort of taking healthcare out into community settings. I want to describe a model practices discovery method that was used to identify some of these distinctive capacities of reach. And then using 4 examples from 4 sites that I've been working with to demonstrate some of these characteristics that bridge culture, mistrust, low income, and geographical barriers. What you'll hear about is the role of trusted networks, as we've been hearing about a lot today, in relationships. The nature of these faith-based and community organizations as being very flexible and adaptive and responsive to the needs of vulnerable populations, and then being able to bridge some of these barriers with language and cultural meaning making. So the background to the work was that beginning in 2009, we worked to build capacity and mobilize a network of these 10 sites to reach vulnerable populations, priority populations at that time, with H1N1 prevention services, education, and vaccines. The work with these 10 sites was built on some history that was supported by the CDC, a leadership development program that we developed and conducted called the Institute for Public Health and Faith Collaborations, where we trained 78 teams of religious and public health leaders in 24 states to collaborate on eliminating health disparities. So the administration's Center for Faith-Based and Neighborhood Partnerships knew about this work and saw, as H1N1 hit, that tapping into the resources and community capacity of these sites might be an expedient way to reach some of the priority populations with H1N1 services. So that's how it began. And these are the 10 sites that I've been working with for the last 7 years. And I think understanding the nature of these partners, these collaborating entities, is important for this work. 4 of them, or 5 actually, are large faith-based health systems who, because of their faith-based mission, have really have a strong commitment in their community outreach programs to build strong institutional relationships to the faith-based community in their catchment area. We worked with Jennifer Delahaye in the State Department of Health at Arkansas. In Detroit, we've worked with a small FBO that conducts really large-scale health promotion and disease preventions in underserved communities in Detroit. In Los Angeles, we've worked with the Buddhist Chu Chi Foundation. That's a medical relief organization that is based in Los Angeles but has locations throughout the country. In Lowell, Massachusetts, one of our first panel's exemplars of a federally qualified health center that has really exemplifies work in reaching refugee and immigrant communities. In Memphis, Minnesota, and New York, those were both large faith-based health systems. And then in Pennsylvania, a small nonprofit that serves a rural community. So accomplishments can be measured of this initiative in numbers and numbers of people vaccinated across the 10 sites. This gives you sort of an idea of the number of events that they've held and the number of persons vaccinated. Along with vaccinations, they conduct a lot of educational outreach and engagement with partners. They've adapted Jennifer Delahaye's flu workshop. Some of the sites have. It was Wisconsin's. But we've further disseminated that through these sites. Thank you, Wisconsin. One of the sites has an academic partner, and they did some qualitative research with religious leaders around trust, and they've built some educational and reach tools using that. Minnesota's conducted, on behalf of the State Health Department, some leader interviews on emergency communication. They've conducted a lot of outreach using different sources of e-newsletters, radio, family nurses, and other faith-based organizations. This last year, 2015 to 2016. The chart on the left represents Colorado Springs, the number of people that are, wait, it's not low enough so you can't see. The number of people that had never had a vaccine before, that are uninsured, no insurance, and those that are insured. And then on the table on the right is Los Angeles and the ethnicities of persons reached through their network. In Minnesota, Fairview Health Services, in some of the first years of this initiative, had a CDC EIS officer working alongside them who helped them develop a survey to administer at these clinic events to learn about why people's attitudes and decisions about having vaccinations, coming there to get their flu shots. And they've done that at the sites every year since then, with an average of 1,600 to 2,800 surveys each year. And you'll see that insurance, the shots being provided for free, a trusted place or setting, and convenience have been kind of the what those participants have said why they're there. So alongside the numbers, one of the things that I've made a commitment to is to be able to engage in some work to try to describe what is the distinctive capacity behind the numbers. And 3 years ago, we conducted a sort of modified Delphi technique with an iterative process to identify some of the key practices associated with the success of their reach to particular populations. And what we discovered is something that we call the Model Practices Framework. This is in a toolkit that many of you have. So these 14 practices, we organized them into 4 core drivers that you'll see in the center, and 5 processes that that circle the that are the motion that circle outside the core gears, the foundational core drivers. And those processes are the day-to-day work that make them contribute to their success. And then along the bottom are 5 infrastructure capacities that are enduring and support their work over time. The 4 sites that I'll now describe as examples represent what was really a strong common theme across these model practices, as you would surmise was the element of trust and the nature of tapping into that trust, building it, and how to sustain it and maintain it. We partnered with ASTO, the Association of State and Territorial Health Officials, who was our funding partner with CDC Monday. It came through a cooperative agreement through ASTO to us. And we partnered in building a toolkit using the model practices. And for those of you who do not have a copy of that, I'm happy to share a PDF with you or a link to our online resource for that. So the first model is our partner, the Buddhist Chi Medical Foundation. And they exemplify what is what was distinctive in these organizations is they're a little light on bureaucracy and have built kind of agile organizations that can be very responsive. And so they show up at different times and at locations where our partners in public health weren't often able to do. This group in Los Angeles would set up clinics and health services out at migrant farm worker camps really early in the morning before the farm workers started work, or they'd be there late in the evening as the farm workers ended their work. They did the same with homeless shelters, because many homeless, you know, they're out in the morning and then they come back at night, so they made the services available to them at those times that were convenient. They also serve large amounts of the Asian population in Los Angeles, and often are present with a lot of services and educational information at cultural celebration venues. The model that I mentioned earlier, the Lowell Community Health Center, is a federally qualified health center, has a long history of responding to the needs of immigrant communities, particularly the Cambodian refugee community, and in more recent years, African immigrants. And they're very innovative in making institutional adjustments to respond to those needs. Early on, for the Cambodian refugees, they partnered with a Buddhist center and actually built a meditation center room in the federally qualified health center. That's grown to become a kind of a pretty large set of east-west integrated services for the Cambodian community called the Meta Health Center. They now have a really strong outreach relationship to a network of African churches, and they've been really intentional about hiring staff who represent the ethnicity and culture of those that they serve. They've adapted the community, they have a large community health worker program, and they've adapted that to work and build relationships and connectivity to these different ethnic populations through the faith-based and community organizations. The picture on the left is a community health worker training being held at the Buddhist Center. And then on the right is a flyer for a fundraising event around Ebola. And this was held largely by the network of African immigrant churches in partnership. The Lowell Community Health Center supported that, but because of their history and trust in that community, they were the real go-to source for Ebola information and the kind of support in the community around Ebola response. Chicago, a long-standing partnership between Advocate Healthcare, which is a, sorry, I'm scrolling, so I'm trying to, don't make your eyes jump. Long-standing partnership between Advocate Healthcare System, which is a large faith-based provider in Chicago, with the University of Illinois Chicago and their Neighborhood Institute. Formed a partnership called the Center for Faith and Community Health Transformation. They have an extensive and strong partnership network into faith and health, like-minded partners and organizations throughout the city of Chicago. And they have a unique communication capacity based on relationships that they've built with this network with trusted messengers, religious leaders, where they're able to translate and make accessible what they call whole person health information. That kind of language comes from their being able to develop language that is meaningful to the faith community. An example of that is their partnership with the Council of Islamic Organizations of Greater Chicago, and they worked together to craft a message that reflected the theology and the beliefs and traditions of the community of Islam in Chicago. And you know, there are a lot of long words in here, so people have to be pretty educated to read it, but it was meaningful in a different way culturally to this, and they were able to distribute this in the Islamic Council's e-newsletter that reached about 9,000 readers. Since then, they've gone even further, and on their website, they have a sampling of small videos, 2-minute videos of religious leaders with encouraging words out of that faith tradition around promoting flu prevention and flu shots. They have one in Arabic, one in Chin, one Hispanic, and one in Haitian Creole. Interesting. I don't know the story behind that. Do I have my, oh, I'm time. 2 minutes, okay. So in Minnesota, the fourth example, this is a pretty large-scale effort built out of Fairview Health Services, which is another large faith-based health system, and in collaboration with the state health department in their health disparities program. So they've worked to reach a really diverse ethnic immigrant community in the Minneapolis area, and they host many events at churches, mosques, a Hindu temple, a Buddhist monastery, a Burmese Baptist church, Somali Mall, a Hmong flea market, homeless shelters, etc. And they hold pretty large-scale vaccinations and have kind of been developed as the go-to flu vaccine site for many of those populations. They only host clinics at the invitation of the host site. That relationship is really respected and nurtured. They are well staffed with trained volunteers who go there on all the hours that are convenient for that entity, those groups of people. A lot of their clinics are on Saturday or Sunday, and they have a pretty extensive now translation process that they use. So this is kind of a little snapshot of some of the diverse ethnicities that are reached by the MINI project, Minnesota Immunization Network. And I will close with my key points, my 0 minutes here. This is outside the health system, but it's still part of the larger community health system. Trusted and accessible messages are often transmitted through trusted networks and relationships. Partners who have flexible, adaptive organizational capacity, and behind that are certain commitments to be able to do that, and those who deliver messages in a language and with relevant cultural meaning. So often that the meaning might be in religious meaning and values and beliefs. Most communities have leaders and organizations like this with relationships and the kinds of commitments to serve in the public sphere that can leverage connections and social capital resources for the well-being of the community. I was fascinated by Dr. Geltman's example of the role of the Brazilian church, that they functioned as kind of a mediator of trust for the patients that they were sending to him, that they were recommending him. So there was this community infrastructure of trust, which I call sort of bridging social capital, that said, yes, get this health care or get this, go to this healthcare organization. And I'm pretty committed to and concerned about the levels of mistrust in healthcare providers and government, and it's very rewarding to see what these community networks and leaders have been able to build over time in their communities. And I'm honored to be working with them and sharing their work with you here. Thank you.